is a morphological and functional unit of nervous system which can generate and receive, process and integrate, and disperse information by conducting impulses from one cell to the other. There are more than 100 billion neurons in the nervous system. They transmit impulses by releasing neurotransmitters at synapses, that is junctions, or may release neurohormones into the bloodstream. Each neuron has got a body and, a, and multiple processes. There are two types of processes. Number one is dendrites, which are short one and are of variable number, and each has got afferent terminals at their ends. The second one is an axon, which is one in each neuron and is covered with myelin sheath and has got efferent terminals at their ends. There are two types of neurons, sensory and motor. At present, we are concerned with the motor neuron. A motor neuron is a specialized cell whose body is located in the motor cortex, brainstem, or spinal cord, and its axon projects to the spinal cord or outside of the spinal cord to directly or indirectly control effector organs, that is muscles or glands. There are two categories of motor neurons. One is upper motor neuron, the other one is lower motor neuron. Now, first the upper motor neurons. Cell bodies of these neurons are located in cerebral cortex and brainstem. Although they are not motor neurons in strict sense, but conventionally they are classified as motor neurons because their stimulation produces movement and their destruction leads to disorders of movements. They are represented by bed cells, the largest cells in the cerebral cortex. They have got diameter up to 0.1 millimeter. They reside in layer fifth of the primary motor cortex located in precentral gyrus. Their fibers are segregated into bundles which travel through brainstem. Majority decussate in medulla oblongata, others do not. Both these groups descend in spinal cord to the level of the appropriate spinal nerve root. They terminate at lower motor neurons directly or indirectly, and they secrete glutamate at their nerve terminals. As regard their function, they directly or indirectly influence or modulate the activity of lower motor neuron, and their action mostly is inhibitory on the lower motor neurons. Now the second group, the lower motor neurons. The bodies of these neurons are located in anterior gray column of spinal cord and as motor cranial nerve nuclei in brainstem. Their fibers extend to elicit response in muscle or glands. They have got glutamate receptors on their bodies. Both conscious and unconscious regulation of these cells is achieved by several upper motor neuron pathways, that is, they are influenced by upper motor neurons. They innervate all the skeletal muscle directly, hence they control the activity of the motor system. They secrete acetylcholine as neurotransmitter at their axon terminals. Sometimes they are named as final common pathway as they are the final link in motor pathway to the muscles. According to their targets, these lower motor neurons are divided into three main or broad categories. Number one, somatic motor neurons. Their cell bodies are located in ventral gray horn of spinal cord and their fibers project as spinal nerves. They innervate skeletal muscles of limb and trunk and they are involved in locomotion. Second group is special visceral motor neurons. Their cell bodies are located in brainstem as motor cranial nerve nuclei. Fibers project as motor cranial nerves, innervate skeletal muscles of head and neck region. They are involved in facial expression, mastication, phonation, and swallowing, etc. Third group is general visceral motor neurons, which are part of autonomic nervous system, and their cell bodies are located in brainstem and spinal cord. They innervate indirectly the cardiac muscles and smooth muscles of viscera, including vessels. Fibers travel in cranial and spinal nerves. They synapse in autonomic ganglia, that is sympathetic or parasympathetic, and postganglionic fibers directly innervate visceral muscles and gland cells. Notable point about the lower motor neurons. Number one, all lower motor neurons and postganglionic parasympathetic neurons release acetylcholine at their terminals, hence they are termed as cholinergic neurons. Most of the postganglionic sympathetic neurons secrete noradrenaline at their nerve terminals, hence they are named as adrenergic or noradrenergic neurons. Most command pathways for skeletal and bronchial skeletal muscles are monosynaptic, that is, they involve only one motor neuron. Motor command pathway for visceral and cardiac muscles are disynaptic, that is, they involve two neurons. Number one, preganglionic neuron whose cell body is located inside the central nervous system, and postganglionic neuron whose cell bodies are located in peripheral nervous system. Now we come to the signs produced by lesions of the motor neuron. First, the upper motor neuron. As upper motor neurons are mostly inhibitory in their action on lower motor neuron, lesions of these neurons produce signs of release phenomenon in the shape of spasticity or hypertonicity of the muscles, exaggerated deep muscle reflexes, that is hyperreflexia, clasp knife response, which is an initial resistance when attempting a passive movement of the limbs followed by rapid decrease in resistance. And colonus is usually present, which is involuntary and rhythmical repeated muscle contractions. In addition, severe paralysis is present with no atrophy at all. Positive Babinski's sign is present in the shape of extensor plantar response. Associated pathology mostly is the lesion in the internal capsule area, leading to production of hemiplegia. The signs produced by lesions of the lower motor neurons, as lower motor neurons not only innervate but are also responsible for well-being of the muscle. Lesions of the lower motor neuron produce the signs in the shape of number one, paralysis, that is muscular weakness, flaccidity, that is hypotonia, loss of reflexes in the shape of hyporeflexia or areflexia, muscle fasciculations in which are involuntary muscle twitches, muscle degeneration, atrophy, and contracture, and the associated pathologies of lower motor neuron lesion are seen in the shape of Bell's palsy, bulbar palsy, poliomyelitis, and amyotrophic lateral sclerosis. Now let us discuss the motor neuron lesion effects. First, the upper motor neuron lesion effects. Before we proceed to the effects, let us have a brief review of the upper motor neurons. In case of pyramidal system, the upper motor neuron cell bodies are located in the cerebral cortex, and their fibers are divided into three parts: anterior corticospinal tract, which controls contralateral axial muscles; number two, lateral corticospinal tract, which control contralateral appendicular muscles; and corticonuclear tracts, which have got bilateral control on the head and neck region, except there is only contralateral effect on the lower part of the face and genioglossus muscle of the tongue. By keeping these facts in mind, let us discuss the lesion effects. First, the left-sided upper motor lesion of the face. As lower part of the face has unilateral opposite-sided representation in the facial nerve nucleus, hence in the case of left-sided lesion, the right side of the face is affected, and the angle of mouth is pulled towards the side of the lesion by the healthy muscles. The upper part of the face is spared as there is bilateral control. Number two, left-sided upper motor neuron lesion in the internal capsule leads to right-sided hemiplegia. Before proceeding to the lower motor neuron lesion effects, let's have a brief review of the lower motor neurons. The cell bodies of these neurons are present as nuclei of the cranial nerve in brainstem and ventral gray horn of the spinal cord as the nuclei of spinal nerves. All these neurons control ipsilateral side of the body and can be affected by number one, trauma to a nerve; number two, viruses which selectively affect the ventral horn cells or cranial nerve nuclei, producing certain lesions. Let us have a review. Number one, left-sided lower motor neuron lesion of the hypoglossal nerve. In this case, genioglossus, which is responsible for protrusion of the tongue, is also affected. So the tongue is pushed towards the side of the lesion, that is left side, by unaffected healthy muscles of the opposite side, that is right side. In case of the face, right-sided lower motor neuron lesion of the facial nerve nucleus produces effects in the shape of the wrinkle-free forehead. Eye of the affected side is quite open, and the angle of the mouth on the left side is pulled toward the unaffected side by the healthy muscles of the unaffected side. Comments and suggestions will be welcomed. Thank you for listening and watching.